I'm taking it just like y'all. I say that a lot in the morning. I'm not really. Once I get into the room, like normally, not always, my energy picks up. I was just telling somebody that as we go further in this semester, you'll see me react off the y'all sometimes. And I'm probably the only instructor I ever see that I'm known for every now and then yawning during my own lecture. And I don't know how that's possible. Because you're supposed to be like real nervous up here and all amped up. I guess I get too comfortable. We're going to finish out. I didn't have a thought of the day. So I always try to come with a thought of the day. Let me think of one. So I was rushing to get y'all's practice test thing posted up for you. In my computer, I turned it in yesterday to re-image, and I walked off, and I was getting out of my car, and I looked at the sheet, and it said somebody else's whole name and laptop serial number on it. I went, great, I'll never see that computer again. Anyway, they'll find one for me, I'm sure. Thought of the day. All right, what do they say? Change my mind. Somebody changed my mind. Property tax is the biggest scam ever put on the American people. Oh, yeah. Nobody's changing my mind. You pay it off, you work hard, the American dream, you pay off your house. You don't ever own it. You're just the person who lives in it and pays rent in the form of property taxes even after you own it. That's crazy.
Hire a lawyer, get 100% disability, move to Texas or Florida, and you don't pay property tax.
I have 100% and I don't
Well,
pay.
then you don't have property tax.
Yeah.
I say his
That goes back
when
when we were. That goes back what we were talking about in the back of the room. Also, when I walked in,
You gotta mail boxes out.
we have too much stuff in our lives. I think, and psychologists even say that. I want to go back and just live in a cabin in the woods, but I'm guilty of collecting all this crap that we have that think is going to make us happy too. And I actually have more than one house, so I still got to pay property tax.
You're living above the American dream, man.
I know. So it is. You're getting both points I've made this morning. It's my fault.
You need to go back and watch Fight Club.
Yeah.
All the shit you own is owning you.
It doesn't change the fact that property taxes. Okay, I'm going to shift it on you now. They take houses from people in some states because they're 65, 70 years old. They can't afford the property tax, so they lose their house that they've owned for 50 years. They worked hard, paid it off, retired, and they go and take their house. That's wrong. Yeah. Oh, yeah. I looked it up. In Texas, probably you gotta have more than 2 or more. And I'm thinking,
How many kids you got?
I got 5 kids. No. I wonder if it counts if I told the kids to cremate me and my wife and just scatter the ashes and put up a headstone on the property. No? I don't know. They probably don't want to live in Bernie the rest of their life. They'll sell it and buy more junk. Okay, here we go. That was a good opener. I love the interaction. We don't have much to go for the rest of this. We'll probably only go this first hour, and then we'll open that test up for you at 9. It's going to open, and you can do that. You can do that from now until the exam. It'll be open. You can take it all you want. Just to get an example of some questions. Connective tissue. We left off. Let's back up to show the. We were going over these classifications of connective tissue. We already covered embryonic, and we were moving into mature connective tissue when we cut off yesterday. And so you'll hear it called connective tissue proper, mature connective tissue. Generally, though, we break it down and say, well, are we looking at, is this a loose connective tissue or a dense? And so we're looking at the characteristics of this tissue. A lot of the locations for loose connective tissue is deep to the skin. So when we see things that fall under the classification of loose connective tissue, you're going to see words like one of the most widely distributed connective tissues in the body, which is coming up next, areolar connective tissue, because it underlines, when we talk about subcutaneous, we know that we've got a large subcutaneous layers throughout the body. That involves a lot of loose connective tissue. Mesothelial linings, right, when we look at different inside the body, they'll have some loose connective tissue under. And this weather. I love that we get heat advisories. Protect yourself. We got it. Check off on that. It's gonna be hot again today. That's all I know. That's good. I like it when it's hot versus cold. Somebody must have complained about how cool it gets in this room. Because did I say on it? Don't ever complain about the temperature. If you complain in this room or there's one or two other rooms, over the years I've wondered kind of which rooms are connected. Because this room may be connected with one on the other side of the building. It's crazy. But if somebody complains that it's too cold, it'll be hot very quick. They'll shift it. Next thing you know, you're in here and wanting to be in PT, but it's kind of muggy in here today. You don't think so? Sorry, I didn't mean to get off topic. If you find a loose connective tissue that surrounds like blood vessels or even like a ureter, they'll name that loose connective tissue adventitia. And that's a change in the word. It's still loose connective tissue, but it's implying that now this loose connective tissue is kind of anchoring something in place, like a vessel or a ureter. And then glandular parenchyma are the around the glands. So the three types we see are areolar connective tissue, adipose connective tissue, and then what's called reticular connective tissue. As we look at each one of these, you're going to see that I list what cells are in there. Well, all connective tissue pretty much has the same cells. So you don't have to relearn that for every type of connective tissue. You got to have fibroblasts. You're generally going to have all the rest of them also in that connective tissue. Because connective tissue, by definition, when you compare it to like an epithelial tissue, has fewer cells but more ground substance, protein fibers. So you'll have all these cells. That's not going to change. What's going to change is the type of fibers that we have in it. So if you have a loose connective tissue, it has loose collagen, lacy reticular fibers. It just doesn't worry about lacy, just some reticular fibers, and then a very small amount of elastic connective tissue. It goes back to what I said yesterday, is that all of these connective tissues not only have these cells, they generally have all three types of the fibers. But it's how much do they have, right? So they have a little bit of collagen in this one, a little bit of reticular fibers, and then a few elastic. And so that's our loose. We got to talk about each one though. If you look at areolar connective tissues, you're going to see that the subcutaneous layer of the skin, like I said just a second ago, is made up of areolar connective tissue. So you're going to find it everywhere in the body pretty much. If you look, and that's all we kind of need to pick up on for now. And when you look at adipose connective tissue, they don't call it one of the most widely distributed connective tissues, but technically it is. Because when you look at subcutaneous layer, there's often some fat, so adipose tissue associated with that. When you look at adipose tissue, we think of storing fat, but it's also, that fat's going to be used for energy, but it's also going to be used to protect certain organs, like the kidney has a fat capsule around it. The adipose cells themselves provide good insulation for heat, so all of that helps you. And then I didn't mention, but adipocytes come from, are derived from fibroblasts. So you'll have some fibroblasts that will change into adipose cells. You start needing to store more fat, you can make more of them. Reticular connective tissue, going back, I'm not going to change anything. Here we're calling it a loose type of connective tissue. Yesterday I said, just think of reticular connective tissue as in lymph nodes in the spleen. They form the stroma. So if you looked at you're holding up the spleen and you cut it in half, it would kind of look all cross-hatched in there because it has reticular fibers. And you can picture like red blood cells going through that and getting kind of hung up in the meshwork. That's the reticular fibers. Same thing with lymph nodes. That's how they kind of sequester and trap like bacteria and virus. So those are our loose connective tissues. And then we switch in and say, well, what about dense connective tissue. Right? So dense connective tissue, it sounds like it's going to be confusing, but it doesn't have to be. There is dense regular connective tissue, and there's dense irregular connective tissue. I'll show you that the difference is really not that big. They're still both dense. And then elastic connective tissue, or a tissue that has large elastic properties, falls under dense. You could almost say, I think they should have called it dense elastic. Because the point there is that compared to like a loose connective tissue to an elastic, like lung tissue, it just has a whole bunch more of elastic. So the elastic's dense. Does that make sense? Because we find elastic in all tissues, but not to that level. Right? So anywhere in the body that needs like tensive forces, like we said, collagen has a tensile strength of greater than steel. I'll leave it to somebody else. Don't start yawning back there. Good. You're trying to make me yawn. Just like else. But if you're pulling on something versus folding, the tensile strength is how strong, how much can it hold. And so dense connective tissues are very strong, but they're flexible. So dense regular just means that if we know, I didn't finish my thought, but on the last thought, if you're talking about a lot of collagen, a dense amount of collagen, and it has a tensile strength greater than steel, that's going to give that tissue a greater strength than other connective tissues. And what they're doing with dense regulars, they take the tissues and you have a bunch of parallel patterns of collagen packed very densely. Right? And then you're going to have fibroblasts and ground substance that are there because you always have those. You're just going to have a lot more collagen in those. So if you look at things like a tendon or a ligament, they're going to be made up of dense regular connective tissue. Think of a tendon coming off of a muscle, or your Achilles tendon is a good example. It always has kind of a tension on it, right? And so you stretch your calf, you pull on that Achilles tendon. Those are straight, kind of parallel collagen fibers that are giving it that strength. Because when you look at a picture, and once again, just kind of an example here, not a labeling picture or anything, is all the collagen is going to be like this, kind of wavy, and then here we have our fibroblasts kind of mixed in. There is still ground substance there, but when you would look at it under a microscope, you can see it's very packed with collagen. There's not as much like ground substance associated with it. Generally dense, I didn't put it on the slide and that's fine, but generally dense connective tissues do not have a great blood supply either. Ligaments, tendons don't heal well, right? Then I said you don't have to confuse them. Dense, irregular connective tissue has the same kind of properties. It has a lot of collagen. And the reason I use the Achilles tendon, because we know how the Achilles tendon pulls, kind of in this fashion, right up and down, if you're looking at the back of your leg. When you look at a dense, irregular connective tissue, all it means is that when they look at it, the collagen, well, we find it in different places because the collagen is not arranged in those parallel rows, it's just everywhere. And so if you picture like taking a balloon and stretching it, that would be more of an example of a look of dense irregular. It's any tissue that forces are exerted on small angles. So like a heart valve, or I think we listed pericardium, the perichondrium, dermis of the skin. Right? As you get deeper, just so people don't get confused right away, I said areolar connective tissue is part of the subcutaneous. Well, part of your dermis is also, as you go, say it differently, as you go down through the epidermis, the skin cells, and you get into the dermis does have loose and dense. It gets kind of more dense as you drop down to it. We'll see that next slide, but that's why that's up there. So if you looked at it under a microscope, this is what you would see. Kind of a scattered picture. Once again, don't worry about labeling these crazy pictures, right? You're still going to have your fibroblast out here. So that's the biggest difference between them. Where you find them because of how they're used. And And then elastic connective tissue is mainly elastic fibers with a few fibroblasts in there. Okay. Believe it or not, it has the property of elasticity. I know that's surprising because of its name, but you remember my fancy graphic, elastic tissues can stretch up to 150% of their normal length, and the key is they come back to their resting length. Anything greater than that, you're going to start tearing. Like if you have somebody who gains weight really fast or pregnancy, you can stretch that skin, the dermis. And once you get so far out of that, you'll start to develop striae things because you form basically that dermis. You stretch it out, it can't return to its length. And there's what it kind of looks like. Alright, so the last two here, muscle, muscle, and liquid connective tissues A&P2, we get our bone and cartilage we'll cover for next test. Alright, we're just trying to introduce ourselves to these connective tissues. So muscle and nervous, we'll spend a lot of time on next test. As we finish out, the last thing we kind of look at is membranes. Because we're talking about connective tissues, and membranes are. We've named them as being connective tissues. But we're going to look a little more specifically is if you look at like an epithelial layer, even like your skin, serous membrane, all of them, epithelial tissues generally line a membrane. So when you see mucous membranes, serous membranes, we talk about them in relation like visceral, parietal, portal, which are types of membranes, serous membranes, cutaneous membranes. All of these are generally associated to have an epithelial layer with them. Epithelial means more cells, right? That was our covering and lining. But underneath them you have this membrane. So we got to look at it. Well, once again, I kind of mentioned it already. What's the difference between a mucous membrane, a serous membrane, and a cutaneous membrane? And I threw on there so when we talk about joints, you'll understand there are also synovial membranes. So some joints in the body that are very mobile, like your knee, have a synovial membrane inside of the capsule. And it's there to, we'll leave it, it's there to help lubricate that joint. In that case, when you look at a synovial membrane, well, just the way it is, it doesn't have that epithelial layer. So, makes it an exception. Made me think of a testing. Now, all my testing stuff is not always for me. It's for as you go through this program. I like to change people's way of thinking because I want you to do well throughout this whole first year. And so I tell you these all the time when I think of them. And if you don't like it, I mean, I'm not going to worry about whether you like it or not. But it's because I hope it helps somebody all the time. Because some people don't think the same way. And you see it along the schoolhouse. And you talk to them in your office. And you're going over like a cardiology test with them or something. And you're like, well, why are you thinking different compared to the rest of the people in the class? Why did you see it that way? And you hear it. And you start to see patterns of certain people the way they think. And I know y'all don't know where I'm going yet, but it's all based upon looking at like synovial membranes. We went over it, we kind of passed on it. What was the key thing I said about synovial membranes compared to other membranes? They don't have an epithelial layer. And so the point I'm getting to is a lot of people roll past that like, okay, well great. All right, but not in this schoolhouse. In this schoolhouse, and I even threw the word out there, I said, okay, well this one's an exception. A lot of people study what they should, like, oh, well they said that's important, I know the whole list, and then they throw out this exception. Well, if it's the exception, it's not very important. No. Even here in other pants, in this schoolhouse, the exceptions become the questions. I'm not saying I do that. I know some of y'all are nodding your heads because you know that structures do that. But around here, I want you to always pay attention. I was talking about my class. I want you to pay attention to if there's an exception to the rule that you're learning, make sure you know that exception. And anything that you ever see in a book, a slide, the teacher says it, if if they say these words, you start. Most common. Most common. Most common. If they say this is most common, those generally wind up in question. Like they should, because we should be studying the most common disorders. But don't ignore the exceptions. So, I mean, because some of y'all do. Some of y'all go, well, that's not important. It's an exception. Yeah, it is. It makes an easy question for somebody to write because they know you won't pay attention. Not always me. Okay. That was good stuff, whether you liked it or not. Mucous membranes. Mucous membranes line a body cavity that opens directly to the exterior. That's the key difference between that and serous membranes. So your digestive tract, your reproductive tract, urinary tract, all of those open to the exterior. And when we look at these areas, you just have some commonalities. We don't want bacteria in the body. If you remember that fact, then you learn all the characteristics easily. But if I don't want bacteria in the body, the cells that are close to that opening, I'm hoping have some tight junctions. I want the cells to be able to control what gets into the body, so some tight junctions. I also am going to need some mucus. Now, if you think about mucus in your nose, it traps dust particles, bacteria, things that come in there, but it also helps to move that out of the body. Or I guess you could say sometimes you swallow it into your stomach, right? But where it's very acidic and it can kill that. So the mucus is protecting you, but mucus also helps you to taste and smell. And you can't taste or smell anything that's not water soluble. So we'll get to that in special senses. But the characteristics of this tissue kind of tell you that. It's not on the slide, but what's another type of cell that we want to have that we discussed yesterday close to openings? Y'all remember that? What's that? Well, goblet cells, they make the mucus. White blood cells, macrophages. How about B lymphocytes? Yeah, all of those are correct. Y'all are correct. I said those are all important. But in my mind, I was already locked on the B lymphocytes. So y'all had good answers. But remember I said that's how you're going to produce antibodies. So membranes, if you look at them, this is a mucous membrane. It will always have an underlying layer. And we're going to call it something different. Right? This is areolar connective tissue. But when we find areolar connective tissue under a mucous membrane, they're calling it the lamina propria. A lot of times you see that everywhere. That blue there is the basement membrane. Where the basement membrane is at the basal layer of those cells. And underlying this layer, we'll call it lamina propria. But it's just the underlying connective tissue. And you can actually see on here, this is your small intestine, but there's a lining here of just some villi up there, and then you have the mucus that kind of sits on top. A serous membrane is different because what its lining does not open to the exterior. So it's covering organs or it's covering the walls, the thoracic wall inside, the abdominal wall. Right? And if we go back and talk about them between the visceral and parietal layers, right, they're next to each other. Your lungs are up against the chest wall. And so your lungs, the chest wall has a parietal layer, and the viscera, being the lungs, the visceral layer has the lungs there. And in between it, you have a space. And you can name that space oral space, depends on where you're at in the body, pericardial space. And it has fluid in there, right? Serous fluid. And it helps them to slide so they don't stick together and you don't have friction. So if that's happening, you have some type of infection, inflammation in that area, that's not going to be good. There's your serous membrane. Looks kind of the same, but a lot of serous membranes, the cells over them tend to be flatter, or one layer. That's fine. It's covered. We were defining things out before saying, well, it's endothelium, like a blood vessel, mesothelium, covering serous membranes, still epithelial cells. we're not going to go into the skin just yet, the cutaneous membranes, because we spend the whole first part of block 2 after we take the test in however long it is next week. Then we'll get into those pretty deep. We will mention synovial membranes again. I've already said kind of everything that we needed to know, but here's the actual slide. Is generally very mobile joints like the shoulder, the knees being the best example, have synovial capsules. Right? So synovial joint capsules are a type of serous membrane because they don't open to the exterior. In this case, they don't have that epithelial layer. We're going to spend, here and ortho, you'll spend a lot more time talking about serous membranes and how they line areas. Basically what a synovial membrane is you have synoviocytes that are associated with it, and they will release synovial fluid into that joint space to help protect it. It's like oil in your knee, Synvis. Some of y'all know what that is. And then as we're finishing this out, which I got down a little quicker than I thought I would, even though I expanded on the slides, because the definition's coming up for all yours. This is interesting to talk about though. It's a good thing to finish with. Autoimmune disorders. Everybody's heard of autoimmune disorders, right? An autoimmune disorder is for some reason, and sometimes they figure it out, sometimes they just don't know, but for some reason your body decides to start producing antibodies against your own tissues. And so autoimmune disorders mean that your body's immune system has decided that certain connective tissues in your body, because autoimmune, let me say, I like to say things different ways. What does micro studies the immune system? And I told you that your immune system is found within your connective tissues. So autoimmune diseases will affect your connective tissues. See, I had to link that back for you. So autoimmune disorders are going to affect multiple areas. Right? So I put an example. Some of these you may have never heard of, but rheumatoid arthritis. Right? If you have somebody, now this is not a die-hard statement. If you have somebody who has, wrist pain, and it's in both wrists, and, there's more of a history you need here, but we're being kind of general. Both wrists hurt them. You're going to at least have rheumatoid in your differential. But if it's just one wrist or one knee, right, it's probably osteorelated. Right? And the point I'm making is autoimmune diseases tend to, whatever connective tissue that autoimmune reaction going on is happening, tends to affect throughout the body. So let's say you had an autoimmune disease that's affecting like areolar connective tissue. I need to look this up. I'm not sure. Maybe I don't know. I'm going to think that scleroderma affects areolar connective tissue, where you scar down the skin. I don't know if that's a true statement. I've never even looked that up. I just thought about that. My point was being is if I told you that you got an autoimmune disease that's affecting your areolar connective tissue, that's going to be widespread. It's going to affect that everywhere. It's going throughout the body. Right? But some target just certain tissues. Why? Who knows? What set that off? Who knows? They're looking into it. There's others like myasthenia gravis, multiple sclerosis. I mentioned MS is a big one for that. Systemic lupus erythematosus. That's why they just call it lupus. Right? Lupus. So all of these, scleroderma would be in there too, but all of these are autoimmune disorders. Yeah.
Is there a difference between like the synovial capsule and the bursa, or are those two the same things?
Was bursa on one of the slides?
No.
I'm just, sorry. Often when y'all ask me a question, I start with where's this coming from, and I was like,
I just was thinking, is that the bursa or are those two separate things, the bursa and the synovial capsule?
Once again, y'all ask some great questions. That's a great question. They are separate. Like a knee joint, let's use the knee. And I'm going to give you kind of an ambiguous answer because a bursa and a synovial capsule are technically two different things. But like in the knee, the synovial, bursa is full of synovial fluid that's around the knee. And so, could you say they're the same thing? Yes, but we don't describe them that way. But there are 14 different bursa, generally of the knee, and then there's the synovial capsule. But they do communicate with each other. Because you do find synovial fluid in those bursa. Right? Not always, but they're not really the same, but I see where you're going with it. Does that make sense?
Yeah, thank you.
I always ask that, like I said, because when you threw out bursa, I'm like, I don't think I've even mentioned the bursa. So I'm trying to, you throw me off a little bit when y'all do that, and I love that, but I'm like, I thought I knew every word on every slide. I don't think we've gotten to bursa yet. That's why I keyed in on them. Alright, so these, and I don't like to read every word on every slide, so these definitions are yours. Right? To look through. And these are words that I've found with students over the years. And you put them in a question, and it's really a distractor in the question or something, but they don't really need it there, and they didn't know what it was. Now, Marfan syndrome doesn't fit that. I'll come back to tissue rejection. So, just a few definitions. Marfan syndrome is, you read these definitions, read the bottom. It is a connective tissue disorder. And I put a lot of info on here, and I'm not going to ask you about it. I think it's interesting, even though it's on here. I know, read through it, because you're going to see it. You're going to study it later. And I had a question a long, long time ago that had something in it about that. But people with Marfan syndrome, read the definition, tend to be tall, have disproportionately long arms, legs, fingers, and toes. So some things I leave in my slides, because it gives you a good time to kind of get outside of the lecture, is I learned Marfan syndrome when I was here. And what I learned about Marfan syndrome, because we were a little bit cruder, I think we're getting back to the crudeness in classes compared to how, y'all don't know what I mean, but back then they would say, okay, so somebody, you look at differentials. When a person steps in front of you in a clinic room or anywhere, you have, you really need to decide very quickly, sick or not sick. I do this. Not everybody does this probably. But sick or not sick. Like, am I going to RSI this person in the next 5 minutes? Or do I have a couple of hours to figure this out, or weeks? And are they sick or are they not sick? And so you look for signs in people, what you can observe, right? They're going to tell you their symptoms. And so you learn a lot of medicine. It sounds negative, but you learn to judge people by how they look that day. You judge, I'm not talking about society, you judge people in medicine based upon their age, their height, their weight, their race, right? Everything. It's how they look. It gives you an idea. And someone with Marfan's, they told me when I was in school, said, yeah, you'll have somebody who comes in with, they're tall, they have disproportionately long arms and legs and fingers. So somebody with, they were describing people with like arms where their fingers are down past their knees or close to their knees, because most people's aren't. Most people's are not. That's not right. And at the time, I remembered that. But Marfan syndrome also has stuff that goes along with it, like heart murmurs, and these people need to be checked out. Here's the story, and then I'll be done for the day. This is a true story. I was working with the Texas National Guard, and they sent us down. I was doing it for fun. I went down to the Colonias, Texas border. If you didn't know it, we have just south of here, not very far, down by Brownsville and things, we have a third world country situation in our own state. Right, where you go down there and people don't have insurance and they can't get school physicals for their children that they need. And so the Guard goes down and does like Operation Lone Star. And there's a lot of other purposes to it, but for my purpose, they said, hey, will you go down and do physicals on school physicals? So they set me up in this elementary doing physicals on kids. And I mean, you're just cranking them out. What I learned the first day, I learned two things. One, they came to me very quickly and said, hey, you just saw. So when you see the kids, the parents come with them. And you're supposed to treat the parents too. And we're not talking like medicine like you're used to. This is like overseas medicine. You got a headache, throw something, right, here you go. But they came to me and said, hey, you got a couple adults come in, they had high blood pressure, you didn't give them anything. I mean, you're not really doing a full exam. I said, well, I was a new PA back then. I said, well, I'm not gonna give somebody blood pressure meds that I'll never see again. It's not an emergency, right? They have high blood pressure. I said, but they're not gonna ever see a provider. They don't have medical insurance. Who's gonna check this? And they're like pulling me to the side and going, listen, you write on the script. This still didn't make sense to me. He said, you write the script. We're gonna give it to them in the next room because we brought all the meds with us. They said, we're gonna give them 90 days of the supply. We're gonna give it to them. And I said, okay, well, what are they gonna do after that? And they said, well, that's not our problem. And a guy that was there translating, he said, he was from Mexico, and he said, no, listen, they're going to, you give them the script, then they'll start buying it in Mexico. You tell them to take it, they'll keep taking it. I guess for the rest of their life, they'll take 10 milligrams of something. You know, they'll just keep buying it. I'm like, so they're never going to see anybody again. And they said, well, that may be the danger, but you're helping in some way. And I'm like, you know, as providers and new providers, especially, like, that's like helping you. But in that situation, I guess it is. It is true. I wish I lived closer to Mexico so I could cross over and buy some cheap drugs. Anyway, I learned a lot in that trip, and the story point, and I remember bone point, was I'm doing all these physicals on these kids, and I'm getting tired, and this kid walks through the door, and this is the crude part. Don't take it out. I always got to preface this, because people took offense to this once. I'm like, we used to say